So hello everyone, welcome to another careers talk from Mind the Bleep. Today we've got Rozina doing a talk on obs and gynae training. So hope you guys enjoy. Remember to put any questions that you have in the chat and we can ask them if we've got time at the end, and fill in the feedback forms at the end too, and then you'll get your certificate of attendance. So do you want to take it away, Rozina?
Yeah, can everyone see me?
Let's just make sure.
So I'll just start sharing my presentation.
Can you guys all see the screen and hear us? Just pop yes in the chat if you can.
Can everyone see that, yeah?
Yeah, they can.
Okay, brilliant. So my name is Rozina. I'm an ST5 obs and gynae in the Northeast Deanery. And I'm just going to do a little talk about obs and gynae, what it involves, typical sort of day in the life, week in the life, and how to apply. So obviously it's split into two different specialties. The kind of things that you do in obstetrics, and obviously this list doesn't cover everything, but in obstetrics, generally there's a lot of antenatal clinic. You review your antenatal women that are admitted, your postnatal admissions. There's the pregnancy assessment unit, which is kind of like A&E for pregnant women. There's fetal medicine, there's maternal medicine. So fetal medicine is a lot of sort of scanning and ultrasound and diagnostic tests like amniocentesis and sort of making diagnoses still in utero, whereas maternal medicine is a lot more sort of mums with health conditions like they themselves have epilepsy, cystic fibrosis, heart conditions, that kind of thing. So it's really interesting. And obviously the bulk of your on-calls is covering a lot of those other things, but also labour ward as well, which is where all the drama happens. On labour ward, you've got all your women who are labouring. You would obviously be doing any instrumental deliveries, so forcepses and ventouse deliveries and C-sections, but it's not just the deliveries. Obviously it's reviewing the women throughout the labour, looking at the heart rate trace of the baby, checking that sort of mums are okay during the labour process. And then gynaecology, I think they're completely different, obstetrics and gynaecology. Gynaecology is very much a surgical specialty. So it's kind of like a surgical job when you're doing it. There's a lot of theatre time, then reviewing your post-op patients. Gynaecology does cover early pregnancy though, so up to 14 weeks. So again, there's some scanning there and sort of looking after miscarriages and terminations and that kind of thing. Acute gynaecology, so people coming in with ectopic pregnancies or big ovarian cysts or ovarian torsion, that kind of thing. Gynae clinic makes up a lot of gynaecology as well, so sort of reviewing menstrual problems, pelvic pain, ovarian cysts, that kind of thing. Theatre time obviously is everyone's favourite, and then obviously gynaecology covers menopause and fertility, and the rapid access clinic, which is when GPs would refer anyone who's got any sort of red flag symptoms in a 2-week wait to the gynaecology clinic. Usually that tends to be things like postmenopausal bleeding or ovarian cysts and things like that. So this is a typical week in my life. So I am part-time, and I think it was about 3 or 4 years ago that they have changed the rules that you can go part-time just for any reason really. Previously you needed to, have a child or be a carer for someone or that kind of thing. But now you can go part-time if you want to, which makes a massive difference in work-life balance. So I went part-time about two years ago, and it made a massive difference. So I'm 80%, so I have Mondays off. But the rest of my week looks like, so on a Tuesday I could have antenatal clinic in the morning and then gynae clinic in an afternoon. Wednesday would be an all-day theatre list, and that would be things like, for example, just Wednesday gone, I did a couple of diagnostic laparoscopies, and then there was an ovarian cyst for a lady that had endometriosis, and then there was 5 hysteroscopies on the list. And obviously at my level now, a lot of those things you're sort of doing independently, like under the supervision of a consultant, so that's quite fun. Thursday I was on call, so that's a long day, so 8:15 a.m. till 8:15 p.m. and that's, like I said, covering labour ward and covering pregnancy assessment unit and the wards and that kind of thing. Obviously, if you work in big tertiary centres, you tend to have a separate obs team and a separate gynae team, but I'm working in a DGH at the moment, so when you're on call you cover everything. Friday, I would have, for example, gynae clinic in the morning, and then in the afternoon, the early pregnancy assessment clinic, which is sort of like women who are sort of less than 12 weeks that have maybe had some pain or some bleeding, and we're sort of scanning those. And then Sunday, I happen to be on call again. So it's quite a varied week. And obviously you can see that there's a couple of long shifts in there as well. Like I said, I'm part-time, and you can make that decision at any point in your training. You are supposed to get some admin time as well for sort of doing audits and presentations. Depending on how full your rota is and how many trainees you have, it varies as to how often you get some admin time. Some weeks you don't get any, other weeks you can have like half a day session, which is quite good and useful if you do get that time. But one of the main complaints I think trainees have is that we don't get enough admin time. Every week there should be local teaching in your local hospital. So I currently I'm the teaching coordinator at my hospital as well, so we all take it in turns to sort of teach each other and do presentations, and get the consultants to supervise that, and then they do sessions for us as well. And then once a month there's mandatory deanery teaching as well that all the trainees have to attend. Through lockdown that stopped happening in person, which kind of made it a little bit more accessible, because lots of time obviously somebody's going to be on call and not manage to go, but now the sessions are recorded so people can catch up with them at a later date and things, and do them from home. But they've just started to be in person again last month, which was really nice to see everyone again. And obviously study leave, so there used to be a set budget and a set amount of leave that you could take, but now, well, I think there's still a set amount of leave that you can take, but the study budget is just whatever your educational supervisor deems appropriate. So if you want to go on a course, as long as your supervisor thinks it's appropriate that you want to go on that course, then money isn't really an issue with that one. So I don't know how many of you probably watched This Is Gonna Hurt, or you've read it, but I think a lot of people, especially medical students, have said, is it really like that, and is that what your life is like? And in many ways, yes, it is. And in lots of ways, things have become a lot more different than the TV program or the book would suggest. So I think these are all sort of my opinions, but the positives to me are that no 2 days are the same ever. Like every single day, even if you were doing antenatal clinic day in, day out for 2 days, you'd still have completely different days because patients can be so different. Generally, your cohort of patients is fit and well young pregnant women who are only there because they're pregnant, and other than that they don't have a lot of medical conditions. And I find that quite attractive in the specialty, because when I was an F1 and F2 I wasn't particularly medical, and I just it depends on your personality, but a big problem list of like 30 things used to really put me off. I enjoy my theatre time. You get lots of scanning practice as well, and obviously you get signed off to scan, and that can be obstetric scanning or gynae scanning. Delivering babies, I've been doing this 6 years now, and I'm still not bored of it at all. I think it's such an important moment in people's lives, and I really enjoy doing that and being present for those moments. And the procedures are really satisfying as well. Like like doing a C-section or doing a forceps or even doing a laparoscopy. Like they're quite satisfying procedures, and they're quite quick procedures. You're not in theatre for hours and hours and hours. You know, it's all quite quick, and sort of high reward. You do have continuity of care, because obviously sometimes you see a woman right from booking her pregnancy right up until her delivery, and obviously you get that with the gynae ladies as well. The cases can be really interesting, depending on where you work as well. Like even like the social aspect of like pregnancies and deliveries and stuff like that, it is really interesting. And generally, most of the time, you have mostly happy outcomes on labour ward, which is always fun. But the negatives or the challenging aspects of the specialty is, no 2 days are the same, and that can be quite draining, and you just never know what you're going to expect. And some days, you know, and if you just want to sort of like quietly get on with something, like there's not much scope for that. There is a lot of exhaustion and burnout, and that's especially when you sort of look at the full-time rotas. They are really, really busy. Like, for example, at my hospital, you would do a week, so you would do 4 night shifts in a row, and then the week after you'd be on 4 long days, and then the week after you have like an 80-hour week of like being on call Monday, Tuesday, and then not on call Wednesday, Thursday, but then being on call again Friday, Saturday, Sunday, and it adds up to a lot of hours, especially if any of the days that you have to stay late. And that was one of the reasons that I went part-time a couple of years ago, just because at that point I was just really, really, really exhausted, and I thought it would be like beneficial for my health if I just cut that down a little bit, and it did help. It is quite high pressure, obviously, labour ward. There's quite high stakes involved. There's a lot of emotions at stake. People really, really just want a nice, happy, healthy baby delivered. And, you know, there's certain emergencies on labour ward that are so time sensitive. You know, if you're having a hemorrhage, or if you've got like a baby is stuck or something like that, you're dealing with like seconds rather than minutes. So it is quite high pressure, but that's that is quite enjoyable as well at times. It is emotionally draining. I would say, like, you know, there's days where you have to counsel like 3 miscarriages in a row, or you have a bad outcome on labour ward or something like that, and obviously those. It's you wouldn't be human if that didn't affect you emotionally, but I do feel like it does come up a lot in our specialty. It can be quite traumatizing at times. Obviously, it's labour, it's delivery, there's a lot of blood. We get you know, F1s and F2s rotating through and GP trainees sometimes, and I don't think they're sometimes prepared for how dramatic things can be sometimes. So it's really important to sort of be supportive for those people, because it can be quite traumatizing, and it's a very big learning curve. It's big, it's steep, there's loads to learn, but again, I find that quite enjoyable. This is the timeline for training. So obviously you would do your FY1 and FY2, and then apply to training at that point, and then it's a run through program. So once you get in ST1, it's a straight career path all the way up to ST7. Your ST1 and ST2 is your basic training years. That's when you'd be classed as what we call like an SHO, or I think that term is quite outdated now, but that's what everyone uses. So you'd be on the SHO rota, and then sort of by the end of ST2, you'd be looking to get sort of signed off for doing C-sections, forceps, ventousas independently, a basic laparoscopy, that kind of thing. And then you would progress to registrar, so that's ST3 onwards. To start ST3, you have to have passed your Part 1 Mrcog exam, and you can do that anytime, even in foundation training, which I think I do recommend, just because it's a really horrible exam. It's, you know, it's all your embryology and your biochemistry, and it's not entirely, like, I can't think of many things that come up from my Part 1. So when you're fresh out of medical school and you still know all that stuff, it's probably a good idea to get it done then. But you know, I did mine in ST1, and that was absolutely fine. And then you start your ST3, so you're a registrar at that point. And then intermediate training is ST3 through to ST5. By the end of ST5, you need to have completed your Part 2 and your Part 3 Mrcog. It used to all be one big Part 2, but now it's split into a Part 2 and 3. So Part 2 is a written, it's clinical and guideline based, and Part 3 is an OSCE. I sort of recommend doing your part 3 very close to your part 2 while the knowledge is still fresh. At that point, you would then apply to what you want to do for your advanced training. So your ATSMs are advanced training specialty modules, and they can be anything from maternal medicine, fetal medicine, fertility, early pregnancy, acute gynecology. I'm doing mine in benign abdominal surgery, so lots of laparoscopies and open surgery and that kind of thing. Some are more competitive than others, and you sort of have to pick 2. Alternatively, at that point, some people decide to go down the subspecialty route, which would be fetal medicine or maternal medicine, and then that sort of like you leave the training program as such, and you just sort of become subspecialist in that area, and then get a consultant job in that specific area. So the application process, so we've had a few of our junior doctors applying for this year. So applications open in November. It's all sort of like no sort of white space questions. It's just a general application form. And then there's a standard long listing process. There's the MSRA exam that you have to do in early January, which is not specific to obs and gynae. It's basically, I think you just have to do it even if you're applying to GP training or any sort of training really. So it's general clinical. People say it's sort of like finals level kind of exam. And then if you get selected for interview, they tend to be in January or early February, and that makes up 75% of your interview score. At that point, offers are made in March, and then if you have an offer, you would rank your deaneries and specific hospitals within those deaneries, and then posts start in August, although there is a bit of talk of maybe delaying. It varies through the hospitals in the country, so I think down south some people start in September, up north we still start in August. The interview process, it's changed since when I did it, but I've obviously seen what the current situation is, but I did have the 3 the stations. So you have one clinical prioritization station, and this is, again, it's not specific to obs and gynae. It can be anything. So it's just a general ABCD situation where they give you some examples of some patients, and you sort of say what order you would see them in. Then there's a communication station, and again, not specific to obs and gynae. I think I had a lady who had a lesion on a chest x-ray, and it was just going through that with her. And then there's a panel interview where they would look through your portfolio and see if you've demonstrated like commitment to obs and gynae and why you want to do it and how much you know about the application process. So in that portfolio station part of the interview, the things that you can do to sort of talk about in that part of the interview is in your foundation years, try and get an obs and gynae job, because in those 4 months you can learn a lot. You can get some assessments done. You can start seeing how you actually like the job. It's a really, really useful way to see if it's going to be for you. Some people take a gap year and do a bit of obstetrics and gynaecology work, or they get a job as a teaching fellow after their F1 and F2. And again, that's a really useful way to get involved with the specialty and start building up your portfolio. You're only allowed 18 months max of experience before that's too much. So if you have more than 18 months, you wouldn't be able to apply to ST1, but then you might be able to apply to ST3 onwards. Obviously get involved in audits and quality improvement projects. There's always registrars looking for help with their projects that they're doing. So you can get involved with that from sort of medical student stage, or even F1 and F2. While you're at medical school, obviously, I don't know if every university has these, but SSC, so student selected components, part of your curriculum. So potentially doing those in obs and gynae and then gaining some experience at that point. The Rcog has a careers day every year. I think it's in June. So that's a useful thing to attend. There's obviously, even if you're in F1 and F2 and then you don't get allocated an obs and gynae job, you can still apply for a study leave week and do a taster week in obs and gynae, and that again shows commitment to the specialty. You could sit your part 1, all the sort of transferable skills When I was on sort of a surgical job, I tried to sort of go to theatre and do some suturing and just general clinical prioritization and things that are always useful in obs and gynae. And then if you're very academic, you can submit applications for RCOG prizes, and there's awards for foundation doctors as well. Why did I pick the specialty? So I like it because it's a good mix of medicine and surgery. We get a lot of theatre time, but it's not just pure surgery. When you're in your clinics, in antenatal clinics and gynae clinics, there's lots of medical options for all of the certain patient symptoms as well. So you get to sort of use your brain and do lots of medicine, but then also get to use your hands and do lots of surgery as well. Obstetrics, like I said, it's high drama, it's high pressure, but it's also very sort of like high reward, and it is good fun, and like there's a lot of teamwork involved with the midwives and nurses, and everyone sort of works together to make sure labour ward's running effectively, and it is good fun most of the time. Gynaecology is sort of my special area that I'm more interested in than obstetrics, just because I really enjoy operating and sort of doing things that are hands-on and developing like surgical skills. Obviously having a baby is one of like the most key events of a woman's life, and it can be, and I think honestly, depending on sometimes care, that can be either a really positive experience or a really negative experience. And obviously the reason I wanted to do it was to just sort of make that experience as positive as possible for those women, because even sometimes if it's a bad outcome, you can still make a difference to how that woman felt at that point in her life. So, you know, that was particularly important to me. So that's why I picked obs and gynae. I think you look at what your personal strengths are. So if you're very introverted and you don't really like lots of pressure and lots of drama, you might be more suited to like radiology or microbiology or that kind of thing. Whereas like I really enjoy like the teamwork aspect, the people, the no 2 days being the same and all the drama. So look at what you're best at and sort of apply to that. And obviously just wanted to be in a specialty that helps women, because that was a proper one of my main interests in life. So that's my presentation. So if anybody has got any questions, or if there's anything that you'd want me to go through again, just let me know.
Hi, Rozina.
Hi.
Hi, thank you so much for that. That was really useful. I learned quite a lot in that as well, to be fair. We haven't got any questions just yet. I don't know if my computer...
someone has just asked if foundation counts as part of the 18 months, and yes, it does, because you would do it for 4 months. So those 4 months do count towards your 18 months. Okay. So then if you were to say go abroad and do a year in obs and gynae, then you're starting to limit how much experience you can have at that point. But before, there never used to be ST3 level entry. That started about 3 or 4 years ago. So that's a good thing now. So obviously there's lots of people like in other countries that are really experienced in obs and gynae, and then they were limited from applying to ST1, but now there's the ST3 to 5 level entry as well. So that's really good for people like that.
Okay, so you just apply straight to ST3. Is that how that works for more than 18 months experience?
Yeah, so that tends to be people who are like from other countries who've got lots and lots of experience. I would say you could, I suppose, if you're signed off for a lot of the procedures, and you've done experience in gap years and things like that, then yeah, maybe you are better suited to the ST3 level entry. Personally, I'd sort of want to start at the beginning and go all the way from ST1. Someone's asked, if we get rejected on initial specialty training, can we reapply and take an F3 year? Yep, that happens to lots and lots of people because it is quite competitive. So that's probably a good chance to do a year as a teaching fellow, or take a gap year or locum in obs and gynae for a bit, and then definitely try again. There's no, I don't think there's a limit on how many times you can apply. So that's absolutely fine, yeah.
What was your sort of personal experience with getting into the specialty? Sort of how did you go about it?
So I didn't know that I wanted to do obs and gynae. for like looking back, the signs were definitely there, because all my SSEs were in obs and gynae, my audits were in obs and gynae, any projects that we had to do, I would always pick obs and gynae. And even when it came to sort of revision, I realized that was the only thing I sort of really enjoyed. But my plan right from medical school had always been to sort of be a GP, so that was not something that I was really looking at doing. And then it was the last job of my F1 year, and I just enjoyed it so much. And I thought, you know when you're like, you don't even care how many on-calls you're doing, because you don't even see it as work, you just really enjoy it. And then in F2, my first job was GP, the job that I totally was thinking that I would do, and I just absolutely hated it. I really hated it. And at that point, people were starting to apply, because it was my first job of F2. So I applied for obs and gynae. I wasn't sure if I'd get in or not, because at that point I didn't think I had loads on my CV, but then obviously I had done audits in it, I had done SSCs in it, so I did have a fair bit. And obviously from my F1 job as well, I'd got lots of assessments for doing like little procedures and mini kexes and CBDs and things like that. So yeah, I got in when I was in F2. So I went straight from F2 straight into ST1 really. So it was quite boring, but most people take some sort of scenic route into it and do gap years and things like that. Because obviously after F2, you don't really get that chance again, especially with it being run through. So I would probably recommend if you do want to do other things, try and get those in after F2 and then apply after that. What courses would you recommend to improve surgical skills? There is there's an Rcog basic practical skills course, and they run that, and that's when they cover like basic things like suturing and like a basic C-section, and like hysteroscopies, things like that. Generally, like your training will cover all of the surgical skills that you need, but you do have to attend the basic practical skills course in ST1. But if you've already done it as an F1 or F2, you can go at any point. That again is good points for your CV. Any classes that would be beneficial to prepare for med school or for the obs and gynae specialty? Looking into med school, but I'm not sure where to start through my undergrad. I think if you've not quite started medical school yet, I think obs and gynae is still quite far away at that point. So I think just medical school in general, you'll cover obs and gynae. So I don't think particularly there's any classes as such that you could take before medical school that I think would be relevant, because obviously at that point everything changes so quickly as well. So it would just, things that I like just from my own application process, things are so different now. I just sort of focus on med school first. What sort of course should we take to prepare for the I think they mean the Mrcog part 1. So there is lots of courses. There's the Royal College one itself down in London. I did that one, but I didn't find it particularly helpful. I think because it's one of those exams where it's just so in depth with the science, and it's sort of like very like early medical school kind of level exam. There's all sorts of private courses you can go on. I did the ACE course in Birmingham, and I found that really useful, because they just go over and over and over the basic principles. There's other courses, like there's Professor Conji, he does a course in Leicester as well, and I used that one for my part 2, and it was very, very good. Audits, research papers from medicine and surgery count for the interview, or they're looking specifically obs and gynae? No, so they definitely count. You still get marks and points for doing audits and research papers. The only thing I would say is just use them to your advantage, and just use it as a transferable skill. So obviously if you've done an audit in like infection control, that is definitely like relevant to obs and gynae, and just talk about how that would be relevant to obs and gynae. If you've done an audit, I did an infection control one, and then I did one on using local anesthetic for ABGs, which is obviously nothing to do with obs and gynae, but it's to do with sort of like kindness and compassion and pain relief and that kind of thing, which is obviously really relevant to obs and gynae. So you can have other things, but as long as you can relate them to obs and gynae, that's all they need to see really. Is it worth doing the PG cert? Does it give you extra points, or is it worth doing other things to improve the portfolio? Lots of my friends have done the PG cert. I think it does give you extra points because it's still a postgraduate qualification. And obviously if you are doing a teaching fellow year, you might as well get a postgraduate qualification out of it. Other than that, I don't think, unless you want to sort of go into like teaching and stuff later on, it would be useful for that. So it sort of depends. Like if you haven't got in and you're doing a teaching fellow year, or even if you just want to do a teaching fellow year, I would definitely do that just to get the extra points. And since you're going to be teaching anyway, you might as well get the PG cert. But yeah, other things can be just as useful.
So you started working on your portfolio basically in medical school?
Well, kind of. I wasn't thinking of it like that at the time. It was just that those were things we had to do, like a couple of SSCs in a year, and we had obviously on elective. For my elective, I did that in the Caribbean, but it was at a maternity hospital. So like when I look back, definitely I can see that I was definitely interested in obs and gynae. So yeah, just sort of like, if you are interested in it, I would say like from medical school, you don't have to narrow yourself too early. Like I said, anything can be made relatable to the specialty that you want. But having specific things obviously would be good too. But yeah, like obviously medical school makes you do audits, it makes you do presentations, it makes you do SSCs, it makes you do electives. So you get a lot of it just from that anyway. And then obviously in F1 and F2, like I said, you can do taster weeks, you can do jobs in those specialties as well, just to gain more experience. Would doing locum in obs and gynae be seen negatively versus clinical fellow? No, to be honest, we're just grateful for any cover, any staff would be absolutely fine. Lots of the people that I know that were locuming for a year went on to apply to training successfully. It makes no difference at all. Can you do the MRCOG part 1 before the MSRA? Absolutely, you can do it in F1. You just have to have between your part 1 and part 2, you have to have a less than 10 years. So your part 1 basically expires after 10 years. So as long as they're sort of within 10 years of each other, that's absolutely fine. But yeah, you could definitely do it in F1. Do you have to do the full audit cycle to get points? So to get a certificate from whichever hospital you do your audit in, you have to register your audit, and then they usually give you a certificate of completion of the audit. So I would say that as long as you've got your certificate to say that you were part of an audit, then that should be enough. When should we start booking for the MRCOG? What do you mean, like time of year, or do you mean like when in your training? Because the actual sittings are January and July. So if you want to sit in January, I think applications open in October, and it does fill up really, really quickly, and trainees are given priority. So if you do need to sort of look quite early, and then for July you can start applying in May. But it does, like, it is quite a hard exam, so it does take a solid. The guideline is 6 months of preparation. So if you're going to be sitting it, I would be revising for it as well.
What other resources did you use to revise for the exam other than the courses that you mentioned?
So when you're a trainee, you have access to the Rcog sort of trainee platform, which is called Stratog. So that's quite useful, but I found that more useful for my part 2 because it was more clinical. For my part 1, it's your basic sciences. So it's going to sound old now, but back in my day, like it was all like textbooks and things. There's a big Rcog part 1 textbook that's a good couple of inches thick, and that covers the whole curriculum for it. To be honest, there's a lot of question books, and I found question books way more useful. So actually going through those, and I can email you the names of those if you want to share them afterwards. But there's Andrew Sizer, so he's one of the examiners for the part 1. He's written a book. You can get them off Amazon, just part 1 preparation books, and they're just full of questions that come up time and time again. And I found those to be the most useful. And then obviously online resources as well. There's I used passmrcog.com. There's on examination as well, and for your part 2, there's what's something called Busy SPR as well, which is actually what one of our consultants in Newcastle, he developed that when he was a registrar. But that's a really good resource as well.
Okay. Well, if anyone wants any of these resources, if you pop your email in the chat and I can get them from Rozina and then send them to you, if that's all right with you.
Yeah, absolutely fine.
Has anyone else got any more questions at all? Just keep popping them in if you have. I was just going to touch on as well, I know you mentioned audits and things, but what else did you do in your F1 and F2 year to build your portfolio? And also, how did you almost find the time to complete it in time without doing the F3 year?
So like I said, when it came to the application process, in F1 as part of foundation, you have to do an audit.
Okay.
So I used the audit that I just did in F1, and that was a very simple infection control audit. It was just, one of the consultants gave me at the time, and I did that, and I just made it relatable to obs and gynae because there is obviously guidelines for all sorts of infections in pregnancy, and the audit cycle is the audit cycle, and they ask you about that. Do you know the thing that? So as long as you can demonstrate knowledge of the audit cycle and what it involves, and if you've done it, that's still relevant. So I didn't do lots of things like above and beyond. Like F1 and F2 is as busy enough as they are. But I just used my time of doing my F1 job. Like once I realised I was potentially going to apply to this, I just started asking the consultants for assessments and putting them on my portfolio, and then when it came to like applying, printing those off and having good feedback from all my obstetrics and gynecology consultants, and just doing like procedures like bits of suturing here and there, getting involved with sort of like teaching some medical students, that kind of thing. Anything that you would probably be doing anyway, but just do things, get certificates for them, and then use it in your application.
Oh, I've lost you there.
No, I'm still here. Can you hear me?
Oh, there we go. Yeah, you're back. Yeah. I think the internet keeps dropping out. I don't know whether it's me or you, but sorry, right. Carry on. I didn't mean to. So we've got quite a lot of emails popping up.
How much teaching experience is desirable? Like, to be honest, it's not a massive part of your obs and gynae interview, because obviously the interview process is aimed at sort of like F2 level. If you have done a teaching fellow year, that's absolutely great, and if you've done it in obs and gynae, that's great too, because it just shows again commitment to the specialty. But there's not a specific amount of teaching that's expected. Once you start obs and gynae training, then teaching obviously becomes a part of your portfolio, and you need to demonstrate that you can do that. But just informal bedside teaching to any medical students that happen to be on your ward that day, like that's fine, as long as you've got some sort of evidence, like even if it's feedback forms or one of your consultants gives you a certificate for doing some teaching. Like I said, we have local teaching every week, so the F1s, F2s, the GP trainees are really keen to do those sessions, because we can then give them certificates that then they can use in their applications.
Okay, I'm just going to put the feedback link on the chat now as well. So guys, if you fill this out, you'll get a certificate of attendance, and you can use that as save that for your portfolio.
Yeah. And then when you apply in a few years' time, you can say, look, I went to this presentation.
Right, so if you guys just let me know if that's working or not. So make sure you all get your certificate. Is there anything you found particularly challenging about the application process and getting prepared to go into obs and gynae? Is there anything that sort of stood out to you as particularly difficult or the hardest process maybe?
Yeah, I think obviously at that point, demonstrating the commitment to specialty. If you haven't because if at that point I hadn't had a lot of time, I hadn't done anything else, I hadn't like gone away and done a year in obs and gynae elsewhere that would really show my commitment to the specialty. So it was just that's the bit that I was nervous about for the interview. Like, clinical prioritization was fine, the communication station was fine. It was that panel interview that I was like, how am I in my short time of like F1 and F2 going to demonstrate that I am committed? But what they want to know is like, obviously, because your points sort of speak to yourself for themselves, like all the degrees and whatever that you've got, but it's knowledge of the training. Like, they ask you about, like, you know, that timeline that I've showed you. So they would ask you like, at what point are you expected to do your MR, so your GPOT 2? So then obviously you have to know that you have to have that by the end of ST5. There's on the RCOG website, there's a matrix of training, and it's what the curriculum covers and things like that. So having that knowledge of what your training is going to be about, and knowing what you're going to, and they'll ask you like, you know, at what point would you have expected to be able to do an independent C-section? So it's not difficult, it's all available like on the website, but just know what training is going to be like, so that they know that you're fully making a fully informed decision when you're applying. I heard that if we get high mark in MSRA, we get the job right away. So I think there's it's a small percentage of people that score like above a certain amount. They can then bypass the interview stage for even GP and whatever else they're applying to. So yeah, I think that's the case. But majority of people would still have to interview, because it's still very, very competitive. And I don't know how high the mark needs to be in that MSRA, but I have heard of a couple of people getting it. I think MSRA. Sorry, any tips on preparing for the MSRA? Again, it's just sort of like online question banks. Like, I haven't actually done it, but I was sort of helping with the juniors that were doing it, and they were all using sort of like online question banks, like On Examination, and the specific websites for that one as well. Just practice questions, really.
I think we missed one just there, just asking if you had any tips for sort of interview prep.
So what we did with we had an F2 and a couple of clinical fellows that wanted to apply. So what we did was we as registrars, we sort of banded together, and we all just did like little sessions with them. So made like little stations of what to expect. So, you know, practice doing clinical prioritization. There's examples and things on the internet. We've obviously got some in our textbooks and what comes up in our exams as well. So just practice doing clinical prioritization. Always know that, you know, someone who's unstable is going to be your first priority, and that kind of thing. Working on your communication skills, sort of anticipating what kind of stations come up, and just practicing that. So if possible, I would just get a couple of friendly registrars or consultants who potentially do a bit of interviewing as well, just to do some practice sessions with you before the interview, so it's not the first time that you're doing it, and obviously timing yourself so that you're getting it done in the 15 minutes as well.
Okay. We've had quite a lot of questions. That's been really thorough, though. Thank you. I think that will be really useful to everybody.
I hope so.
I think as medical students, you know, half the reason why I want to get involved in this series is I don't feel like we get quite enough information about how to tackle all the applications and what to sort of look out for in medical school, even like extracurricular activities that are good to get involved in the future. So it's so good to hear. I don't think we've got any more questions. So if you just send me the couple of links for the books, and then I can get them sent out to the attendees.
Yep, no problem.
No, they're just saying yes. Okay, well, we may as well wrap up a little bit early then. Thank you so much, Rozina, and thank you so much everyone for attending.
Thank you.
I'll just turn it off. Oh. See you later, guys.
Bye. How many people were there?